Today we're going to review the new clinical practice guideline for endoscopic eradication therapy of Barrett's esophagus and related neoplasia. This guideline was published on May 17, 2024 by the American Gastroenterological Association, or AGA for short. Throughout this video, we will use the following abbreviations: AGA for the American Gastroenterological Association, EET for endoscopic eradication therapy, BE for Barrett's esophagus, NDBE for non-dysplastic Barrett's esophagus, EMR for endoscopic mucosal resection, and ESD for endoscopic submucosal dissection. The objective of this guideline is to provide evidence-based recommendations for the EET of BE and related neoplasia. EET includes resection techniques, endoscopic mucosal resection and endoscopic submucosal dissection, as well as ablation, including radiofrequency ablation, cryoablation, and other techniques. This guideline was developed using the Grading of Recommendations Assessment, Development, and Evaluation Evidence to Decision Framework, also known as GRADE. This framework categorizes recommendations by the strength of recommendation, strong or conditional, as well as the certainty of evidence, high, moderate, low, or very low. So with that out of the way, let's jump into the recommendations. In individuals with BE with high-grade dysplasia, AGA recommends EET over surveillance. This is a strong recommendation, moderate certainty of evidence. Implementation considerations include: after completion of EET, surveillance should be performed at 3, 6, and 12 months, then annually. Surveillance endoscopies after EET should obtain targeted tissue sampling of visible lesions and random biopsies of the cardia and distal 2 centimeters of the tubular esophagus. In individuals with BE with low-grade dysplasia, AGA suggests EET over surveillance. Patients who place a higher value on the well-defined harms and lower value on the benefits, which are uncertain, regarding reduction of esophageal cancer mortality would reasonably select surveillance endoscopy. This is a conditional recommendation, low certainty of evidence. Implementation considerations include: after completion of EET, surveillance should be performed at years 1 and 3 after complete eradication of intestinal metaplasia, then revert to surveillance intervals used in NDBE. The tissue sampling protocol during surveillance should be performed the same as in surveillance after EET for high-grade dysplasia. In individuals with NDBE, AGA suggests against the routine use of EET. This is a conditional recommendation, very low certainty of evidence. In individuals undergoing EET, AGA suggests resection of visible lesions followed by ablation of the remaining BE segment over resection of the entire BE segment. This is a conditional recommendation, very low certainty of evidence. Implementation considerations include: in patients with only a small area of BE beyond the visible lesion, complete endoscopic resection in the same setting is acceptable and may be preferred over repeated procedures to perform ablation. Radiofrequency ablation is the preferred ablative modality. In individuals with BE and visible neoplastic lesions that are undergoing endoscopic resection, the AGA suggests the use of either EMR or ESD based on lesion characteristics. This is a conditional recommendation, very low certainty of evidence. Implementation considerations include: patients suspected of having T1 esophageal adenocarcinoma should be referred for consideration of EET. Endoscopic resection is the test of choice over endoscopic ultrasound for distinguishing esophageal adenocarcinoma from high-grade dysplasia and for staging depth of invasion in early cancer. The vast majority of neoplastic lesions may be managed with EMR rather than ESD. Patients with large, bulky neoplastic lesions or lesions highly suspicious of at least T1B invasion and deemed candidates for endoscopic resection may benefit from ESD over EMR. Patients with previously failed EMR might benefit from ESD. So there you have it, a recap of the new AGA guidelines for endoscopic eradication therapy of Barrett's esophagus and related neoplasia. For more information on this guideline, or to view other resources, visit us online at guidelinecentral.com or download the Guideline Central mobile app available on iOS and Android devices. This has been a Guideline Central production, and we'll see you soon for the next one.